Welcome to our session today, where we're going to be talking about what happened at ASCO, the recent American Society of Cancer Oncology virtual conference, and what the big news is in colorectal cancer. Thank you everyone for joining. I'm going to start by introducing our panelists, and then we will go into a series of questions. So many of you know Dr. John Marshall, a good friend of the Alliance. He is a global leader in the research and development of drugs for colon cancer and other GI cancers. He's the principal investigator of over 150 clinical trials at both the local and national levels. Dr. Marshall is the Associate Director for Clinical Care of the Lombardi Comprehensive Cancer Center and the Chief of the Division of Hematology Oncology at Medstar Georgetown University Hospital. Welcome, Dr. Marshall.
Thank you. Thanks for having me.
Thanks for being here. And Dr. Christopher Lieu joined the University of Colorado School of Medicine faculty as an assistant professor of medicine in July 2011. He trained in internal medicine at the University of Colorado, where he also served as chief medical resident. He currently serves as the Director of GI Medical Oncology at the University of Colorado Cancer Center, is a member of the National Cancer Institute Colon Cancer Task Force, and serves on the National Comprehensive Cancer Network panel for neuroendocrine cancers. Welcome, Dr. Lieu.
Thanks. Happy to be here.
Thanks for being here. So no shortage of credentials from both of you. Thank you again for your time and commitment for bringing information directly from ASCO to our community. It's so important that we're sharing out. And with that, I will start us off with the most obvious question. What's the biggest news out of ASCO this year?
Well, he clearly was working. Look, he's got scrubs on and everything. He's working today. I'm at home in my basement. This is where I went to ASCO. Where'd you go to ASCO, Chris?
Yeah, this is pretty much, I'm mainly at home, but of course it's a little bit later on the East Coast than it is here in Colorado, but I'm on the inpatient service this week. So taking a little bit of a break to talk about ASCO with you guys. So
bless your heart.
Must be a lot more fun.
Yeah, it was weird though, Andrea. I was just saying, because we did ASCO like online. On one level, it was, I thought, really very efficient, but it just missed all the other pieces of why we go to the big meeting. And so from that end, we miss seeing each other and members of the Alliance as well. But I'll let Chris lead it off with the big science that came from the meeting.
So, well, I'll second what John said. I think the beauty of virtual ASCO is to be able to go through so many sessions, fairly quickly. I think ASCO, if anybody's ever been, is just, it's a big meeting, and it's really hard to catch everything that's going on because there's so many things happening simultaneously. At the same time, very, very sad to not meet our friends from CCA and also not be able to see each other. So John and I really want to talk about one of the biggest abstracts that was presented at ASCO. And so they call this the plenary session, and they, these are usually research trials that are practice changing and are considered the biggest things to happen in oncology. And so one of the plenary abstracts, and this is across all disease types, not just colorectal cancer. One of the plenary abstracts was reporting on the Keynote 177 trial, which was a trial for patients with untreated metastatic colorectal cancer that were MSI high, which is one of the biomarkers that we've talked about, which I know many people here on this conference are very well aware of. But this represents about 4 to 5% of our patient population with metastatic colorectal cancer, so about 1 in 20 patients. This is a small group, but it's very, very meaningful because we know that this is the group that appears to have a much better response to some of the immune checkpoint inhibitors or immunotherapy drugs that are currently on the market. The Keynote 177 trial was essentially a randomized metastatic trial in patients that had previously not had any chemotherapy or any treatment before. And so at the time of starting treatment, they were randomized to either receive the standard of care chemotherapy, what we would normally give to our patients that have metastatic colorectal cancer, or they were randomized to receive immunotherapy, in this case, a drug named pembrolizumab. And what they did was compare how long did it take for the cancer to grow on chemotherapy and how long did the cancer appear to grow did it take for the cancer to grow on immunotherapy. And what we saw was a really impressive doubling of what we call progression-free survival, which means how much time did it take for a cancer to grow on a CAT scan. And this really proved that in this select patient population of patients that have MSI high colorectal cancer, when we start with immunotherapy, the results seem to be much, much better. And I'll let John weigh in on that as well.
Well, it was a fascinating study. So first, to get plenary is huge, right? So all of the abstracts that get submitted, these were the top 4 abstracts. And so normally they are shown in a room big enough to hold a tractor pull in, but this time it was, I think we broke the internet actually, because the ASCO site kept crashing during all of this. But you know, Chris, we haven't touched base on any of these, so I'm really interested to hear your thoughts on a lot of this. So I was surprised how quickly they got the trial done. I mean, this required transforming practice so that people were testing for microsatellite instability frontline metastatic before they started chemo. And our culture in colon cancer has been, I think, a bit slow on this. Whereas like the lung cancer culture is, you have to know the molecular testing before you start. Whereas in ours, we sort of think that's the way it should be, but it was nice to see. So I was very pleased that they could do the trial. I was a little skeptical, which also then makes me feel good about the adjuvant studies that are going on. But then the positive results on some level, to me, I was certainly hoping and expecting them. But it's nice to see them. I mean, you asked us 2 years ago if we had had frontline MSI high colon cancer. I think Chris and I might have both looked at each other and said, well, we'd probably try some immunotherapy if we could get our hands on it. And what's nice about this study is it validates that feeling we had, and that's without chemo. So this is a chemo-free approach in frontline treatment. But I'm very interested to see what Chris thinks about the sort of what I call the sort of curve flipping, where initially, like that first few months of treatment, it looks like chemo is actually doing better now for a long, long time. And everybody's got their own theories as to why that might be so. And it sparks more studies, I think, but I'd be interested to see what Chris thinks about those. And we've seen it in gastric, we've seen it in other places too. So we saw it again in colon.
Yeah, so John, I think your video cut out for just a second when you're initially asking the question, but I think you're kind of talking about that flip between chemotherapy seeming to do better in the first 6 months and then immunotherapy kind of taking off after that. And,
yes.
And I certainly want to hear what you have to say as well. So this is actually be very therapeutic, maybe for both. But you know, I think it probably says a couple of things. And I think Mike Overman from MD Anderson did a really great job of reviewing that data. And part of it makes you think, well, were there some patients that had pseudo progression? And what we mean by that is, you know, were there some patients that actually had some inflammation of the tumors? When this happens, the CT scan can actually make it look like the tumor actually got a little bit worse before it gets better. It does kind of bring up that. But I think more likely is that there are some patients that have inherent resistance to single agent immunotherapy. And what I mean by that is that the pembrolizumab, the tumors just kind of figured out a way to not be impacted by it. Whereas in the first 6 months, you're seeing certainly a group of patients that are responding to chemotherapy. And then what happens after that is that you're kind of left with the patients that are having a response to pembrolizumab, the immunotherapy. And then you see those patients do you know, certainly much better. When you look at intrinsic resistance, or you know, basically just not being able to have a tumor respond to immunotherapy, it does make you wonder, number one, you know, is any immunotherapy going to work in that selection of patients? And it does kind of bring up this idea that there's been some data with kind of 2 immune checkpoint agents combined together in the frontline setting. And so there's studies that are currently ongoing that reported out some data that is certainly promising. And I think that if you ask me if, you know, what's going on in the first 6 months, why some patients appear to be doing better with chemotherapy than with immunotherapy, that's my best guess at it.
Yeah.
What do you think?
No, I agree. You know, MS, we have to remind ourselves that microsatellite instability is not a perfect biomarker. we don't really understand whether MSI stimulates immune response because of just sheer number of antigens that are now being presented versus certain key ones. So it's not perfect. And I think we also learned that lesson from this frontline study, is that there's some patients who didn't benefit. And so it's possible that there is a subgroup that it is actually harmful or not as good as chemo would be. So there's more to learn. The lung cancer lesson is that what they've learned is that when you combine with chemotherapy, you do get some better impact up front. And so I'll be interested to see how we learn and evolve. I agree with the concept of dual checkpoint inhibition as a strategy. So this begins really, or continues our journey in MSI high colon. It deserved the plenary. It's transformative for those patients. It's practice changing for us. Now we have to do these biomarkers right away. And we have to figure out what it all means and how to further refine those. So it was exciting,
I'll tell you, one of the things that I think John and I will both agree on is, really what are we looking for when we talk about how long it takes for a cancer to grow? What are we looking for in terms of overall survival, which we're obviously very interested in. And I think John and I have seen, and all of us have seen many trials that kind of show a couple of weeks here, a couple of weeks there. But really what we're looking for are these big impacts. And I think that was one of the things that we saw with Keynote 177, this immunotherapy study, was this kind of big impact of immunotherapy on how long it really took for these tumors to grow. So I think, John and I will kind of continue to preach that this is kind of what we're looking for. We don't, these kind of incremental benefits, it's important to establish those are, and it's good to see improvement, but we want to see these big leaps.
And just like we wanted, of course, we saw much less toxicity with the single drug. The immuno-oncology approach does have side effects, but much different than our traditional chemotherapies. So, I think that bore that out as with quality of life and all those other issues were positive as well. So it's cool, but there was a lot other to cover too. So I don't know if we want to move on, because that is for the MSI patients, and what about for the rest of us kind of stuff.
Big news, clearly. Thank you. Is there anything that you would tell patients if they are listening now and they know their MSI status? How should this shift the way they talk to their medical team?
I think the big take-home point that John and I would probably want to reiterate to everybody that's listening, and even to providers, is the importance of testing. John had already remarked on it. We want to empower our patients to really just upfront ask the question: has my tumor been tested for biomarkers? If it hasn't, when will it be? Or if it has, how will that information change the way you think about how you're going to treat me? Because John and I are going to talk about a couple of other abstracts that really just drive home the point that, again, we're trying our best to personalize therapy for patients with colorectal cancer to get away from a one-size-fits-all treatment. And so we would say, talk to your doctor. We want our doctors thinking about this. There's research that suggests that maybe we aren't very good in the United States at testing for biomarkers in colorectal cancer. Well, we've got to change that, and our patients can play a big role in that.
Yeah, I think we've gotten better, but I also think it's because, as you say, Chris, the patients are demanding it. And, you ask any breast cancer patient, they will tell you if they're HER2 triple negative or ER positive. They know. I think they get tattoos or something that say it, but we need that same culture. And the Alliance has done a great job of informing patients and being the, if you will, self-advocates to drive this, because oncologists are busy and they've got a lot of noise coming at them. And sometimes they'll think, that biomarker matters or it doesn't. Where the MSI study, the Pembro study counts, is that it matters, right? It's going to affect you right from the beginning. And there are different ways to test for the MSI. But the other biomarkers are equally important in the metastatic setting for sure.
And I just want to take that opportunity to plug that the Alliance helpline, if you can call anytime Monday through Friday, 9 to 5, 877-422-2030, and a navigator can talk you through this. So if there's anything you're hearing today and you want support in talking about biomarker testing or other topics, we can certainly help listeners with that. On that point, is there anything else practice changing that came out of ASCO around biomarkers?
John and I wanted to talk about the Beacon trial, which is another biomarker-directed trial. So in this study, and again, this is another, just like the Keynote study, another international trial. So really, really great international collaboration. BRAF V600E mutations, or BRAF mutations, are present in somewhere between 5 and 10% of all patients with colorectal cancer. So again, it's not a huge group, but you're starting to see us kind of piece together more and more biomarkers for our patients with metastatic colorectal cancer. We know that these are a group of patients that have very, very aggressive biology. And what we mean by that is that the tumors seem to grow, they seem to be very unresponsive to a lot of the medicines that we traditionally use for metastatic colorectal cancer. But it also provides a target, right? So if that gene is mutated and we have drugs that can hit that particular mutation, then it does provide an opportunity, even though we know that that cancer is going to behave worse, that maybe we can intervene on that in a very targeted way. So the trial was essentially a comparison between standard of care chemotherapy and a type of targeted therapy called cetuximab. So the chemotherapy was irinotecan. The targeted therapy was cetuximab. Those are standard of care options that we use in patients with metastatic colorectal cancer. The treatment arm, or the investigational arm here, was actually a BRAF inhibitor called encorafenib in combination with cetuximab, which is already FDA approved for colorectal cancer. And then there's another arm that had another targeted drug called binimetinib added. So there are 3 arms on the study: standard of care treatment, a combination of 2 targeted agents, no chemo, encorafenib and cetuximab, and then a final arm that had 3 targeted agents, again, no chemo, but 2 oral drugs and an IV drug. And what they found was that the group that got targeted therapy did better than standard of care chemotherapy. Why is that important? Because number one, we know, again, that standard of care chemotherapy, it just does not work very well in this patient population. Why is that also important? Well, you can actually give our patients with BRAF mutated metastatic colorectal cancer this dual targeted therapy of encorafenib and cetuximab and improve their overall survival. And that's what the Beacon trial results showed. And that's why there's actually now an FDA approval for the 2 drugs, encorafenib and cetuximab, for BRAF mutated colorectal cancer.
Our friend Scott Kopetz really is the one who got this bone. He's at MD Anderson, a great person. He got this bone in his mouth and was not going to let go. And we you know, and by the way, everybody on the call, it's not BRAF. If you say that, you're kind of not cool. So it's BRAF, right? I mean, we're all agreeing on that. But this marker went from being a terrible thing to find on your cancer to at least a ray of hope. That and I actually, what Scott then did was, with lots of help, but kept combining different approaches to actually turn it from a marker that just was bad news to a marker that gave us new therapies. And by sorting this out, as Chris already eloquently laid out, has created a new subset, if you will, of colon cancers. Now it gets tricky because sometimes MSI high patients also have BRAF mutations. And so now you're sitting there, okay, which am I going to use? And I think that those are individual choices, and we can get into the weeds of that. But this made a BRAF positive genetic test something that gave us a real therapy that's now in the algorithm. And it's moving quickly. It's moving quickly into second line, to first line therapy, and to, we think, adjuvant therapy as well. So, you know, what we're seeing is that when we discover these things and we see these big differences that Chris alludes to, we then say, okay, well, we need to change the entire algorithm for those patients, and they begin to become subsets. So at the next 5K walk, scope it out. Maybe we should have little like teams, the BRAF teams over here and the MSI teams. It's just an idea, it's just a thought, you know, and, you know, different t-shirts, this kind of thing would be fun. But these were lessons learned in other cancers that really transformed colorectal cancer. Maybe one other just comment is that because many of the people on the call may have participated in clinical trials. We, for all of these positive clinical trials where the experimental arm was transformative, there were many presented at the meeting where the experimental arm wasn't positive. One that we put lots of patients on was the celecoxib study, where after adjuvant therapy, if you took celecoxib, there was benefit. What the hope was that it would prevent recurrences and the like, and that turned out to be negative. And so when people go on to studies, they often are rooting to be on the experimental arm, but a lot of times they aren't better, and they are more risk. So that we want to continue to encourage people to take these risks, if you will, with us as we try and find these big breakthroughs for others and enroll in these randomized studies. So just one more pitch for clinical trial participation and all that CCA has done to improve that.
Thanks so much, Dr. Marshall. And we have a clinical trial finder on the website that patients can use directly at ccalliance.org. So that's a great tool for finding what makes sense for you.
I might jump on the other major target that we've been messing with in colon cancer, and this is HER2. It was first sort of defined in breast cancer, just like BRAF. It was a terrible marker in breast cancer. And now, crazy as it might sound, you want to be HER2 positive in breast cancer because the treatments are so effective. It's such an effective pathway to hit that it transforms that cancer. It makes it much easier to treat. And so you may not know this as patients, but HER2 is actually found in a relatively low percentage, but some patients with colon cancer. And when we test for it, we now have therapies that are driving towards it. And to me, I thought was an incredibly exciting new approach, which is to take the drug trastuzumab or Herceptin, which was the original sort of blocker of this pathway, and use it, to block the pathway, but I think really more to carry a bomb along with it. So a cousin of irinotecan has been stuck to the tail end of this smart bomb or missile or drone, and it finds its way to the tumor and hooks onto HER2, the marker on the cancer, and brings with it what we call a payload. And this payload delivers to the tumor this chemotherapy. So it's good old-fashioned chemotherapy, but delivered in a very, very clever way. And the response rates were significant, were quite high. And these are in refractory patients, so patients who'd had all sorts of treatments, including irinotecan, many of them. And so this new delivery tool was quite exciting. And so I think that's here to stay and is going to get fairly quickly on our radar. Spicier meatball than some of the other things we've talked about because there's some lung toxicity that's been seen with it and the like. But, my guess is that this is going to move fairly quickly into the HER2 positive space for colon cancer. Chris, you agree with that?
I completely agree. I think one of the interesting things about, kind of blocking that receptor and attaching a bomb to it is that even in patients that were HER2 amplified, so they had that HER2 biomarker that John was talking about, and they had previously received anti-HER2 therapy, which means that the drugs that have traditionally been used in breast cancer, these are the drugs that essentially shut the door. What John is talking about is essentially throwing a grenade in there and shutting the door with the trastuzumab deruxtecan. But the response rate in patients that had previously received anti-HER2 therapy was still somewhere around 43%. That is an incredibly high response rate in patients that, as John had mentioned, had received a lot of therapy, in fact, even a lot of targeted therapy, and whose tumors had continued to grow. So I agree with John. I think the study that was presented at ASCO or virtual ASCO, it was a relatively smaller study, but I think the results are so impactful that I agree with John. I think you're going to see this move forward. And the NCCN guidelines, the guidelines that many practitioners in the United States use to guide care for the treatment of patients with colorectal cancer, already include some anti-HER2 therapy, but we're even looking at even better drugs. And so as you can see, like the theme that John and I are really talking about is, even if it's a small subset of patients, we're starting to chip away at this pie in order to provide more personalized therapy for patients. And so again, not to continue to say the same thing over and over again, but definitely this is why biomarkers are so important and why we need to be testing for all of them.
Yeah, and that, I mean, that also can be very frustrating for many of the people on the call, because if you're not in one of these rare subgroups, you know, you sort of feel like you're left out in the cold and you're still doing traditional chemotherapies. But that's not to say we're not looking at drugs that may help larger numbers of patients or more common populations. That continues. But these that are making the big news because of their prominence and their magnitude of benefit are the ones that really rise to the top for us as exciting. But, you know, so we continue to look, and we continue to look deeper and deeper at other markers. And as we do that, it may make even smaller and smaller subsets. So we all have to work together in this to find these subgroups of patients. I was thinking about another sort of technology. It sort of changes our gears a little bit, but I'm still really excited about the ctDNA data. I mean, it's a new technology which is different than precision medicine in that it's just looking for, if you will, the trash from cancer in the bloodstream, and by finding that, really helping transform some of our decision making. So that's using genetics in a different way, sort of a yes/no answer, presence or absence, versus this other, which is really guiding how the cancer's thinking, how it's working, and getting at from its fundamentals. But there wasn't much new data around ctDNA because we're kind of in the maturing phase of that evidence. But I just want to bring that out before we get into some of the other stuff.
Yeah, I agree with John. You know, this idea of a liquid biopsy, of looking for fragments of tumor DNA in the bloodstream, I think it's really going to be a game changer for all of us in cancer medicine. And, you know, the power of being able to detect biomarkers from a blood draw, I think is only getting better. Some of the application of this technology, which John is talking about, is the potential to maybe even determine whether a treatment might be working. And, you know, in earlier stage colorectal cancer, maybe the opportunity to tell us who may have residual disease following a surgery and who may not, which would be powerful in terms of maybe providing better care for patients that do have residual disease even after a surgery. And in some cases, maybe even not offering treatment to patients who have surgically resected colorectal cancer. And so I would say it's the data is coming. Those on the call are going to start to see more and more clinical trials utilizing this technology to try and answer this question: how can we best use this to guide treatment decisions? And so this is definitely an exciting field. I agree with John.
Yeah, very exciting advancement. We didn't even talk about discussing that on this call, but perfect timing, because the Alliance actually just launched some new information with a video, and patients can go to our website to find more information about ctDNA and also if it might be right for them. So very important medical news. I know we had both of you on, gosh, it must be 2 months ago now, to talk about.
I haven't left my basement for the entire
we just have
2
you
months. They bring
same
me
place.
food down. I have a bathroom over there. My vitamin D levels are very low. So I've just been, that's where Chris was too, as I remember. He was in the office, yeah.
Exactly. Yeah. Well, we're appreciative for all of the time. But it's been a while since we talked about the impact of COVID on cancer treatments and patients in active treatment. And I know, of course, that was a big topic at virtual ASCO when everyone broke the internet. So I guess I'll put the general question out there. You know, what do patients right now in treatment need to know about special precautions they should be taking, or anything else related to the current COVID environment?
Yeah, maybe let Chris go first. Are you all starting to see an uptick now? I mean, ours is kind of flattening to lessening, and I think your part of the country is starting to see a little bit more, aren't you?
Yeah, so, right. I would, to kind of give you the landscape, I would love to hear John's experience. I think social distancing was really saved our hospital system in terms of not running out of ICU beds and ventilators. I think there was a time there in April, which may have been even after John and I had a talk with the Colorectal Cancer Alliance, where we almost ran out of ventilators. But having said that, our numbers, and we kind of hit a peak of about 157 at our hospital with 60 patients on a ventilator, which, you know, again, to tell you guys, I mean, that is a dramatic amount of patients that are in our ICUs. We are now down to about 32, which is about as low as I've seen during this entire pandemic. So certainly we have plenty of capacity now. I think the concern as society and our society opens up is this idea that we are probably going to have a second wave. There's concerning modeling coming out from the Colorado Department of Health and Education suggesting that the peak in the fall may actually be much worse than what we saw in the spring. I think the problem with all modeling in terms of a disease where you don't really know a whole lot about it, it's really problematic and in terms of knowing what's gonna happen in the future. Having said that, I think I would say that we're in a lull right now, but we are definitely on guard. And what I mean by that is that I think we're preparing that things could get worse, but for the time being, things are at least a little bit better right now. But having said that, today I think about 19 or 22 states have reported significant increases over the last couple of days compared to the last couple of weeks. John, tell us what's going on.
We're seeing the same decline, and we were at 23 today. We are all watching these numbers like hawks on a daily basis and the curves and trying to gauge a sense, because honestly, I spend maybe half of every appointment with every patient now talking about COVID and what should they be doing? Can they get a scan? Can they come in and get a test? Should they have that surgery? Should their daughter visit from Denver, you know, to, no, or you know what I'm saying, just, you know, and if they fly in an airplane, should they quarantine before they come to the house, kind of thing. And we are, you know, it was an interesting series of weekends from Memorial Day to Black Lives Matter events all across our country. You know, we're watching the Italian data and the Chinese data to see if they get, you know, second waves, and will it be seasonal versus timing, this kind of thing. We don't know. We don't know what's going to happen. And so from a patient's perspective, my take on it right now still is that, you know, our hospitals are pretty safe places to be. Now that we've opened up again to elective surgeries, we went from having lots and lots of open beds to now we're back to, you know, it's crowded in there with the other patients, not COVID anymore, but the other patients. And while we still need to maintain capacity. So our new patient volume, interestingly, has actually fallen over the last 2 weeks, whereas our follow-up visits are at like 125%. So what we're watching for, this sort of, if you will, mouse through the snake is I think it was CCA who published that there was something like, I don't know, 20,000 undiagnosed colon cancers in the United States out there somewhere because they hadn't been getting their scopes and things. And so I think the dip in news are that we haven't been doing surgeries and we haven't been doing tests. And so the follow-ups are getting in and getting treated and maintaining their therapies. But I do believe we will see a summertime wave of cancer patients coming through, and colon cancer being high on that list. We'll need to study this over time. There's what we call something called stage migration, where if the stages get more advanced, the longer you wait for your diagnosis. So it'll be interesting to compare stages now that come in the door from stages the last several years, for example. And our guess is that there will be more stage 3, stage 4 colon cancer just as a result of this few months of delay of screening and testing. We're doing a lot of video still. I think we're about 60% of all visits are still now televisits. Patient acceptance of that is high. I think we talked about last time the intimacy of that interaction, which is, it's intense for us too. I was a little pissed today. One of my patients, I sent him the link because we have this technology, and I was waiting and I was waiting for him to answer back. And it was like 20 minutes into the visit. So I called him on his cell phone and he goes, oh yeah, I was in a meeting. I was going to come in a minute. I'm like, really? Really? Great. So anyway, be on time. It's all part of the deal. But anyway, it is a new world that we're entering into. And I think we still need to be careful, but I also still really miss hugging people. And, you know, when you talk about patients who are making, I have a great, fairly locally prominent patient who loves to ride his bike, and he's talking to me about being behind a cyclist, and what if that cyclist in front has it, and you know the swirl behind him, and all, you know, he's obsessing about this, and I'm like, go ride your bike, it's going to be okay, go ride your bike. So I don't know if you're being as cavalier as I am, Chris, but I'm like, go out, if you got to keep living.
Yeah, so it's amazing that John and I are on opposite sides of the country, and we're basically seeing the exact same thing. So the exact same scenario that John is seeing at Georgetown, we're seeing here at CU. I would tell you, I echo the fact that hospitals continue to be safe places. We've had about 3,500 patients come through our clinic since the pandemic began, and we've had one patient test positive. And so, you know, I take that obviously to be a good sign. And certainly we're being a lot more cavalier, to use John's word, in terms of our recommendations for our patients. Obviously, we recommend still, you know, social distancing, but at the same time, yeah, I mean, I think our patients have also proven to be very smart and very careful and very cautious. And I think John and I are seeing the results of that as well. But we don't want patients to be paranoid. We want them to still to be living their lives.
Chris, there was that one interesting study, I'm pretty sure it was at ASCO, everything's been kind of a blur, but that patients with cancer, there was lore that cancer patients in general were at higher risk of both getting and then dying from COVID. But there was a big analysis that looked at if you were progressing, if your cancer was growing, you were at higher risk. But if you were on chemo, whatever, and stable, then you weren't at any higher risk. So I've been kind of leaning on that data when I'm making recommendations about whether to go visit the daughter or, you know, go see a grandchild. Is that if you're actually doing okay, I think you're probably no greater risk, at least with GI cancers, colon cancer. Leukemias, they're different, right? But our drugs and our patients, if you're doing okay, I think you're probably okay, just like any of us would be okay to go do whatever it is.
I think that really echoes what you and I have seen in our own patient populations,
True.
Right? And I think towards the beginning of this, we were really worried that our patients were really going to be the ones that would suffer from COVID the most. I don't think that is borne out, particularly in the patients that have been stable and been doing well. And so, I feel very, I think all of us, all of the practitioners feel very, very fortunate that our patients have done so well through this. And I think that's for a myriad of reasons, but I think there's a scientific reason for that as well.
Yeah. So fingers crossed I've actually asked our division to think about sort of July 1st, right? The new residents, the new fellows are coming. Life needs to keep going. We need to keep training doctors, and we need to keep doing what we're doing. Cancer is not elective. And I sort of said, let's see what our new normal looks like July 1. It's going to be a mix of televisits, but fairly normal business, back to inpatient admissions and, all of the stuff we do. Clinical trials back open, this kind of thing. But then sort of look in 3-month increments. What do we look like in September 1? Is it going to be another wave? We're watching the numbers, or can we loosen a little bit more? And so that's sort of the way I'm thinking now for the next maybe year, is in these 3-month blocks of what our resources need to be, what our processes need to be. And we're constantly kind of, which way is the wind blowing on all of this, on a global level, to try and give the best advice we can to each other and to patients.
For everybody on the call, this is why they put John in charge of things. So, and I think that's a really good way to think about it, honestly. And it's just, I think it can really wear on you, right? Because we would love to be able to say, okay, this is all going to be done on this date. And I think that would make people feel so much better. It's just not reality. And I think that that's probably as good of a way to look at it is in those increments, and just kind of, and to be as flexible as possible, and to kind of, move with the changes.
Yeah, that sounds like a strong approach. We're still learning so much. And I know in DC, we are about to go into phase 2 of reopening. So we'll be learning even more. So I know we only have a few minutes left.
We got to talk about neoadjuvant therapy. We have
Go
to.
for it. You asked the question.
Let me set up the big theme, and Chris is much better at the detail. So as I'm looking at it, big picture. So we've changed the rules on how we're doing studies in what we call the adjuvant setting, or an earlier stage, where we used to do huge studies that took years. We would finally present them, and we would make steps. But every 5 years we would make steps. And now we sort of changed it around to where we're doing faster, shorter studies with what we call intermediate endpoints, readouts that are quicker. And one of the things that's the whole trend in cancer has been to move, instead of doing surgery first and then chemo or radiation after, we're flipping it. And that's taking a lead from breast cancer and other diseases as well. And so in GI cancers, in colon cancer, now that our drugs work better, can we flip it? And so the big study, one of the big studies for me, was this taking all of the rectal cancer treatment and altering it and emphasizing by throwing it up front. And I'll let Chris walk us through. I can do it, but you'll do it better.
So, I think I'm going to need some help, because there are 3 studies that I think were impactful in this space. I'll go through a couple of them. I'll hand it over to John for some perspective, and to talk about anything that I may have missed. The standard treatment for rectal cancer, which is what we're going to talk about over the next, 3 minutes in the limited time that we have, is really to do chemoradiation. And that usually takes about 25 treatments over the course of 6 weeks, right? So it's a long, onerous process. And then wait for a bit, do surgery, and do some chemotherapy afterward. That kind of scenarios is how we traditionally done things. And John has talked about moving this treatment and doing the chemotherapy up front and everything up front prior to surgery. And so there are 2 trials that I want to talk about, and there's a third that John may want to touch on. But one of them was to use this total neoadjuvant approach, all this treatment up front before surgery, and to ask 2 questions. One study asked the question, can we get away with a shorter course radiation treatment? So instead of 25 doses of radiation, can we get away with 5 doses of kind of more intense radiation, actually without the use of chemotherapy? And this study showed that what we call the disease-free survival, or how long it takes for a cancer to come back, or hopefully never come back, was actually better, believe it or not, in the shorter course radiation, which meant that we might be able to get away with a less duration of radiation, followed by chemotherapy, followed by surgery. That's really a game changer in terms of how we've always done things. And this endpoint of looking at, well, how long does it take for the disease to come back, and again, hopefully never come back, that's a really, really nice endpoint to look at. The other study was, could we maybe even get away without doing surgery for rectal cancer, which would be a really big change in the paradigm. This study looked at doing either chemo and radiation combined, followed by chemotherapy, and then maybe surgery or a watch and wait strategy if it didn't look like there was any cancer left. And it also looked at an arm where we did chemotherapy and then chemoradiation, and then look and see if we could get away without doing an operation. And in a group that got chemoradiation first, followed by chemotherapy, there's around 58% of patients that actually didn't have to go on to a surgery, which is a remarkable number. Again, I think it's early to kind of say all this is practice changing, because we really do need to see the data. But you're seeing this big thing of pushing all the therapy up front, and maybe able to do some novel things like shorter radiation, or in some cases, maybe being able to avoid surgery altogether.
Yeah, and particularly with rectal cancers, where people really don't want surgery if they can avoid it, these strategies are getting us there closer and closer. Or alternatively, they really don't want ostomies, even if it's a temporary ostomy. And some of this total neoadjuvant approach then means the last thing you're doing is surgery. and then you don't have your ostomy can be reversed more quickly. And so the one thing I might throw in here, and maybe we won't agree on this, is I'm kind of done with 6 months of chemotherapy. The IDEA study finally has come out with an overall survival, and we can quibble about the statistics, but the curves are right on top of each other, that our current standard had been 6 months of chemo for most people after surgery. And this study looked huge, almost 13,000 patients compared 3 months to 6 months. And 3 months looks almost identical to 6 months in terms of survival. And so my thought is that if we're flipping this chemotherapy in rectal cancer to preoperative, and it's like a 3-month window, a lot of the studies tack on another 3 months afterwards, which we rarely can even give, right? So it's an idea in a way that never really happens for maybe as many as half the patients. So increasingly, I think we are going to be done with 6 months, and that we're going to now use 3 months more and more, because I just don't see the real true added benefit of additional chemo. Maybe there's some rare subsets. Are you there yet, or are you still wrestling on that one?
No, I agree with you. One of the big studies in colon cancer was to look at 3 versus 6 months of chemotherapy. And when you look at the overall survival curves for patients that got 3 months versus 6 months, I mean, those curves are completely on top of each other. So it's really, really remarkable how similar the curves are. And so I agree with John. I think the question largely being, can we get away with doing less chemotherapy and therefore spare our patients some toxicity? And the answer, I think, is clearly yes.
Yeah, and I think this will be culture changing for us. I have been raised a get it the hell out of me kind of doctor first, and then we'll ask questions later. And that's the concept of surgery first. But the lessons here are that, our staging has gotten better. Our ability to detect stage 2 and stage 3 disease preoperatively has gotten better. And now with these ctDNA techniques, we're getting the tools that enable us to do reverse this order. And I think shorten the overall treatment, reduce the side effects, and improve the outcome all at the same time. So this is a nice window we're going through right here with putting all of these tools together to really transform the outlook for patients with colorectal cancer.
Yeah, that's really life-changing. We'll need to stay on top of that one for sure. Well, thank you both so much for being here. Per usual, it's so nice to have you and so nice to be able to bring this information immediately to our community. If anyone has any remaining questions, feel free to go to our website, ccalliance.org. And with that, we will conclude today. Thank you again, doctors.
Good to see you, Chris. Take care.
Thanks, guys. Good to see you.
Thank you. Hey, thank you so much, Andrea. I appreciate it.
Thank you so much.
Thank you.
Stay safe, everyone.